Good morning, namaste, namaskaram, warm greetings to you on behalf of Team DentistChannel.Online. Today is the second day of the world's first virtual implant expo. Like you all, we too are very excited, enthusiastic, and all set once again for power packed sessions. Of course, because of the prominent, eminent master speakers that we are blessed with for these 11 days of power packed sessions. Ladies and gentlemen, once again, very warm greetings to each and every one of you. Today, I want you to introduce yourself and tell us which place you are from. If you're from the beautiful city of Tamil Nadu, if you're from Delhi, if you're from Mumbai, if you're from various parts of Europe, Middle East, please tell us in the chat box your full name and the place you are joining us from. Come on, quickly we'll do an introductory session. This is not only for the people who are watching us on Zoom, this is for everybody who's watching us on various social media platforms, for our viewers on Facebook, YouTube, and various other platforms. Please quickly tell us from which place you're joining. Please tell us your full names as well as the place you are joining from. Once again, a warm welcome to each and every one of you who's joined us for the first session. The first session today is, I would say, is for the beginners in implantology. We have two very well-known speakers from Tamil Nadu. Ladies and gentlemen, most of you all know what Tamil Nadu is famous for. Tamil Nadu is called as a city of temples. Tamil Nadu is famous for its food, its heritage, its culture. Tamil Nadu is also famous for these two very speakers. And I can proudly tell you that because of the number of dentists that they are training. And they wish to impart this knowledge to all you lovely people who are joining us on various social media platforms. We have with us Dr. Arul Prakash as well as Dr. Alaguvel Rajan from Tamil Nadu. A small introduction about our speakers. Dr. Arul Prakash graduated from the Ragas Dental College. He later went on to pursue his MDS from the same college. His area of interest includes implantology and prosthetic restoration, and his main focus is in flapless procedures. His desire to share his knowledge in implantology led to successfully establishing an academy called the Nellai Dental Academy, a center which has trained more than 100 dentists in the field of implantology. He has also conducted implant workshops in state conferences and CD programs. He is an active member of the executive committee of the IDA, branch secretary IDA Tirunelveli. He was recently conferred as the national level best secretary award in the dental conference, the Indian Dental Conference 2020, which took place in Kerala. Thank you for joining us, Dr. Arul. It's a pleasure to have you. Up next, we have another budding speaker, a speaker who really has been doing a wonderful job in training dentists from all across India. He is Dr. Alaguvel Rajan. Dr. Rajan finished his undergraduation from Rajaya Muttaya Dental College and Hospital in the year 2008. Then he went on to complete his post-graduation degree in the same college in the Department of Oral and Maxillofacial Surgery from the Annamalai University. He is a maxillofacial consultant in Tirunelveli, Tamil Nadu, and is successfully having a private dental practice. He is working as a reader in Rajas Dental College in the Department of Oral and Maxillofacial Surgery. He has been a guest speaker in Tamil Nadu Indian Dental Association as well as the Association of Oral and Maxillofacial Surgeons in India, Tamil Nadu chapter. He's been invited as a keynote speaker in various forums regarding conventional implantology, basal implants, and minor surgical procedures. He's published articles nationally and has been trained in hair implantation and is certified by Association of Oral and Maxillofacial Surgeons in India. He's also associated with Implant Train, an implant skill developing course for students and dentists. At present, he is the Joint Secretary at Tirunelveli IDA. Ladies and gentlemen, presenting to you the first session of day 2 of the world's first virtual implant expo. Over to you, Dr. Arul and Dr. Rajan.
Thank you, Ruben, for your brief introduction about us. So, may I share my screen?
Yes, sir.
Thank you. I would like to thank DentistChannel.Online coordinator, Mr. Ruben, and other coordinators for this opportunity. I'm Dr. Arul Prakash from southernmost area of Tamil Nadu, Tirunelveli. I was a practitioner. I was reader in Raja's Dental College. Now I'm doing my practice and I am a mentor in Nellai Dental Academy. Thank you. Today I'm going to talk something about the basic principle and basic knowledge about dental implant. What is dental implant? A dental implant is a surgical component that interfaces with the jawbone to support dental prostheses such as crown, bridge, denture, facial prostheses, or to act as an orthodontic anchor. What is the material made up of? The dental implant made up of titanium. We need to know some terminology like osteointegration. What is osteointegration? The basis of modern dental implants is a biologic process called osteointegration, in which materials such as titanium form an intimate bond to the bone. This bond will be helpful in the osteointegration. What are the components of implants? We have 4 components. One is crown or prosthesis, abutment screw, abutment, and surgical post. The implant or fixture or surgical post, it provides an anchor to foundation for restoration. It is screwed into the bone of the jaw, providing a fixed platform on which an abutment can be screwed. What is abutment? Abutment is it provides supports for the crown. It is also interface between the crown and the implant. It has a screw that links the abutment to the fixture. It's made up of titanium. The crown are the top post part of the restoration and are in part we see in the mouth. They replicate original teeth to provide biting surface and aesthetic appearances. Advantages of dental implant. Why dental implant is famous, or why dental implant is recently accepted treatment? Because it has a better aesthetics and better strength, better stability. Due to that preservation of alveolar bone, the resorption of alveolar bone will be less in edentulous areas. Okay, patient come to us for asking for a tooth, not for implants. So we need to convince our patient to put an implant. Okay, before that we need to plan. Failing to plan is planning to fail. If you plan successfully, the result also will be the success. This is an unplanned prosthesis. It's a world largest dental bridge. This prosthesis will fail someday. This is also unplanned prosthesis. They have a 1, 2, 3, 4, 5, 6, 7, and this much cantilever here. Abutment is full of bone loss. Here, see the unplanned prosthesis. It will fail someday. In all on 4, this is an expectation, but this is a reality. They want to place 4 implants, but wherever the bone available, they place it. The final result, it will be very difficult to restore the process in the prosthesis. This is also due to improper prosthetic. They place the implant very labially, here very adjacent to the tooth, here very labially. So avoid this situation. What are the things we need to consider before starting the case? We have to check the available bone and mesiodistal dimension of the edentulous area, the anatomical landmarks, and available buccolingual bone width. We have to, how to check the available bone in the length, the mesiodistal width of the edentulous span. It can be identified by clinical identification, by using CAS, or in the radiographic methods. In the width of the bone, it will be identified by ridge mapping, or it can be identified in advanced radiographic technology like cone beam computerized tomography. And depth of the implant, we have to consider this. We need some anatomical landmarks. What are the anatomical landmarks we need to know to place our plan before implant placement? In the maxilla, we have to think about incisive foramen, lateral wall of nose, and in the posterior maxilla, we have to think about the sinus, anterior wall, posterior wall, and floor of maxillary sinus. In mandible, we have to think about in the anterior region, we have to think about the lingual artery, we have to think about incisive canal, we have to think about the mental foramen and inferior alveolar nerve. Why these areas are important? We have certain limitation for these areas. So we have to know and we have to measure the bone available above that these areas. Then we have to plan for a implant placement. First is radiographic assessment. In radiographic assessment, we have various modality of extraoral radiographs. That is one is IOPA and OPG and CBCT. Why we need to always we prefer three-dimensional view radiographic methods to access the proper planning of implants. Why we need to 3D imaging? This is a patient, 55 years old patient, came to us with a swelling. In the intraoral examination, there is a swelling in the buccal mucosa, and we have missing 4, 5. So we sent a patient for a OPG. We have a well-defined radiolucency here. Some areas in this OPG, we have the radiolucency here also. Some radiologist says it's a multilateral radiolucency. So professional radiographic that's a root resorption is there. So the professional diagnosis was given by the radiologist. The clinical diagnosis is a cyst. That's a periapical abscess. Here, periapical or periodontal abscess. In here, the radiologist told this is a ameloblastoma or OKC. So we sent for a 3D imaging. See, patient have multiple punched out radiolucency all over the cranium, and she have a well-defined lesion in the right side of maxilla. This is a CT report. Have diffuse multiple well-defined punched out cystic lesion in the calvarium. This is suggestive of multiple myeloma. What is the problem if we did a surgery by using that only that OPG? We may be in the trouble. So we send the patient to the Cancer Institute. The patient is fine now. Okay, then what is the proper treatment planning? We need to place the implants between the tooth. We have some criteria to identify the proper case, proper history. After proper history, we have a certain parameters to identify the straightforward case. What is that? This is a magic number called 1, 2, 3, 7 principle. This is a magic number in the implant dentistry. We have 1, 2, 3, 7 principle. What is 1? 1 is after placement of implant. We have 1 mm adequate bone in the buccal and 1 mm adequate bone in the lingual surface. This is a 1. What is 2? The space between the adjacent tooth, abutment tooth and adjacent tooth and the implant is 2 mm. What is 3? The inter-implant distance is 3 mm. What is 7? The inter-occlusal distance and mesiodistal width of edentulous space minimum of 7 mm. What is 1? After placement of implant, we have a 1 mm buccal bone healthy buccal bone, 1 mm lingual buccal bone or palatal buccal bone, and 2, the space between the tooth and the implant is 2 mm, and 3, inter-implant distance is 3, 7, minimum mesiodistal width and interocclusal space is a 7 mm. So 1237 is a magic number in implant dentistry. If the case fulfill all these features, it is called a straightforward case. Straightforward, fulfill all the case. This, see, inter-implant distance is 3 mm. The tooth and implant distance is 2 mm. It has a very good occlusal clearance also, and adequate prosthetic space, ideal soft tissue factor. If the case not fulfill the 1237 principle, it is called as advanced or complex cases. In advanced cases, we have inadequate bone volume, inadequate insufficient prosthetic space, poor soft tissue factors. So we need adjuvant procedure like grafting, rid splinting, sinus lift. So another case is complex case. We have poor bone volume, insufficient prosthetic space, poor soft tissue factors, needs major adjuvant procedure like black grafting, rid split, sinus lift, or zygomatic implants. What does armamentarium need for implant placement? We need a physio dispenser with surgical handpiece and a surgical kit with a ratchet. What is the surgical component? What are the components will be there in the surgical kit? We have various drills. Drills have various laser marking. The laser marking here, it shows the dimension of the drill. This is a 3.2. Okay, this is a 3.2 size drill. We have various laser marking here. This shows 6 mm, 8 mm, 10, 11.5, 13, 16, and this is 19 mm. This is a 19 mm drill in the no risk kit. We have a 6 mm in laser marking. First laser marking is 6 mm. Second laser marking is 8 mm. Third is 10 mm. Fourth is 11.5. Fifth is 13. Sixth is 16. This up to this is 19 mm. This we have various drills. This is a 3.2 mm drill. We have a 2 mm drill, 2.5, 2.8. 3.2, 3.65, 4.2, and 5.2. These are the sequence of drill. Other than drill, we have to know about the implant sizes in various company. In Norris, we have minimum size of 3.3 mm internal hex implant. In the 3.3, we have length is 8 mm. In the 3.75, we have the 6. There is a drill. In the drill, we have a 6, 8, 10, 11.5, 13, 16. Here in the implant also, we have a length of 6 mm, 8 mm, 10 mm, 11.5 mm, 13 mm, and 16 mm. So, how I will convince for an implant case? The implant case, initially before 5-6 years, may also not convincing the patients for the implant. The patient who are all asking for the implant, I will call the consultant and I will place the implant. We place the implant in our clinic. After that, once many of friends are saying they are practicing in the rural, I am practicing in a very rural area. And many of my friends also practicing in rural area, they put more implants. They said, well, you have some problem in your convincing skill. So I started convincing the implant for all the cases. I will inform the patient whether you want to replace only the tooth or you want to replace along with the root. The word, I won't say it's a screw or it's an implant like things. I will say it's a root. It's an artificial root. You want to replace only your tooth alone or you want to replace your tooth along with the root. Many of patients will convince and we can place the implant. Second thing, in the initial phases, I will keep it in mind that 1, 2, 3, 7 principle, and I will the selected in the conventional selected that ideal cases or straightforward cases in the initial phase. I got more success rate, so the patients refers to others, and I placed more implants in we placed more implants in our clinics. So start implant, take your practice to the next level. Thank you, Dr. Ruben. Thank you, Mr. Ruben.
can stop sharing.
I have, may I answer the questions?
Can you able to see my screen, Arul?
Yes, I can see your slide.
Yes, sir, we can see your slide. Please go ahead, sir. Question answer, we'll take it in the end.
Okay, thank you.
Okay, thank you, Dr. Arul, for the introduction. And I will welcome all of the participants from the various part of India as well as various part of world. So here I want to emphasize about some basics of implantology, because in this shorter duration, implant is a bigger learning. So just I will put about some basics of the implantology, and I will thank the dentist channel for giving me the opportunity. Myself, Dr. Alaguvel, an oral maxillofacial surgeon. I will share some knowledge about the basic implantology. So progressive atrophies of jaw. So how Dr. Arul emphasized that about the anatomy of the mandible. So mandible as well as maxilla, there will be more age changes or bony changes will take place. So whenever from the birth to the old age, geriatric mandible, there are numerous modification and changes happen in the bone. So every patient doesn't have the same bone quality as well as the bony anatomy. So we should understood about the mandibular bony changes as well as maxillary changes, which is going to happen in the patient. So we should keen about the anatomy as well as buccal plate and lingual plate. Everything should be 1 mm. That is a basic principle. Why we again and again we are telling about that, because whenever there is no 1 millimeter or on the buccal side or lingual side, there will be the exposure of the implant surface, or you can call as a dehiscence or labial exposure or lingual exposure of the implant, because our titanium conventional implants have a rough surface or a surface coated or treated surface. So whenever it is coming to the periosteum or the external region of the oral cavity or the soft tissue, if it is not completely embedded into the bone, what will happen? There will be an accumulation of microorganisms, then it will develop to a peri-implantitis. So anatomy is very, very, very important to place or embedded your post or your implant, conventional implant, completely surrounded by the bone, not by any of the soft tissue. So always knowing the surgical anatomy for the implant is very, very important. Main thing is to avoid intraoperative as well as post-operative complications. So what are the anatomical landmarks? How much millimeter we should avoid means, if it is the mandible, we all know about the anatomy, inferior alveolar canal, and your mandibular canal is running, inferior alveolar nerve is running. So just 1 millimeter to 2 millimeter from the apex of the implant, it should be above apex of the implant from the inferior alveolar nerve to avoid some major complication. In some situations, we can go nearby the inferior canal, but at least you can leave 1 millimeter. That will be beneficial for the patient as well as successful of your implantology. Otherwise, there will be a compression take place into the canal or to the nerve sheath. It will have some mild paresthesia to moderate or severe paresthesia can also happen. Other than that, from the mental foramen always exits to the second premolar, apex of the second premolar, or usually in our undergraduate we have learned in between the apexes of the first premolar as well as second premolar. But the thing is, what it will happen from the mental foramen, laterally it will exit on the labial side and it will have a S-shaped hook. Sometimes inside the mandible itself, it will go 3 millimeter, 5 millimeter, and take a hook reversely and then exits through the labial. So always manipulating the soft tissue on the premolar, lower premolar region, especially in your mandible, you should be very careful, as well as your angulation of your implant also little bit cautious. In this, you can sometimes you can't believe your two-dimensional X-rays, so definitely you should need your cone beam CTs or three-dimensional X-rays to avoid the nerve injuries. Same thing, your anterior nasal cavity as well as incisive canal should be completely avoided. Nasal probe can be, in your basic implantology, sometimes we usually study that you have to implant your, place your implant on the bone completely. Same way, your nasal floor engagement also should be done to have a good primary stability, because always your implant primary stability will be on the apical part of your implant, mostly depending on the crustal part as well as your labiolingual part. So always concern about your anatomy as well as mandible. So after the anatomy, you should know about our missed classification always, because there are many people here having as a visitors in this forum, but most of them are basic beginners, most of them doing a very good implantology, but anyway what are we should stick to our basics. So basics is nothing but your D1, D2, D3 and D4 type of bone we have heard about whenever talking about implantology. D1 is a dense cortical bone, D2 is a porous little bit, and D3 is the most porous as well as trabecular bone. So how I will compare is D1 is like a concrete or a cemented wall. So whenever you start drilling, you can feel some little bit resistance. So you can feel that as and compared to a D1 type of quality of bone. D2 bone will be, I will usually to understanding purpose, I will compare, it's like a wooden, a good wood or a teak wood. So whenever you drill into a wood, you can make a difference between a cemented wall, drilling into a cemented wall and the wood. And D3 type of porous cancellous trabecular bone, you can drill whenever you drill a nail or drill into a cardboard type of wood, it will be little bit comparatively little bit easier to drill. And D4 type and D5 type, D4 completely trabecular bone on the posterior most of the mandible, I will compare whenever you drilling into a sponge or a thermocol, you don't have any type of resistance. So as a dentist, as a dental surgeon and an implantologist, we should have our hands into the bone as well as whenever we dependent upon your Hounsfield units from the CT, as well as you have to read about your Cbcts and have the volume or density of the quality by radiologically. Same thing clinically you can evaluate, as well as during your surgical procedure, you are able to appreciate how the D1 bone behaves during your osteotomy, as well as D2 bone behaves during your osteotomy, and same comparatively there will be less resistance in your D4. Because why it is very important about your misclassification and D1, D2, then only you can limit your sequence osteotomy drills. Because Arul mentioned that there will be 2 mm, 2.5 mm, 2.8, 3.2, 3.65 that are called as sequence drills. Whenever you do your osteotomy by step, sometimes D4 bone, you have a less resistance, your osteotomy will be little bit converged, then only your implant stability will be good. If it is a D1 bone, complete osteotomy up to the level which diameter of implant we have selected, we are supposed to go through. Okay. So typical anatomical locations where we will find D1, D2, D3, D4 type. D1 most probably in anterior mandible. Whenever anterior symphysial region, there will be a thick cortical bone. Most of the patients in the anterior mandible and lesser patients in the posterior mandible, you can find D1 type of bone. And D2 type of bone in usually anterior mandible as well as posterior, as well as anterior maxilla. Sometimes the pre-maxillary region, there will be thickened region. So sometimes you will find D2 type of bone, which is comparatively resistant like your D1. And D3 and D4 type of porous bones are in your anterior and posterior maxilla D3. And in your sinus region and posterior tuberosity region, there will be D4 type of bones are present. So how you are successful implantology, how will you plan? What are the things you should plan? So always you have to divide it into 3 steps. One is pre-operative evaluation, then during the operative period, intraoperative, what are the things you should be concerned, and post-operatively, how you have to check for your implant placement as well as follow. So pre-operatively, patient evaluation is very must. There are deeper segments are there in your patient evaluation, but I will short note this. Patient evaluation and diagnosis and treatment plan. Always the treatment plan consists of prosthetically driven implant. Whenever the bone is available, you can't place an implant and check for your post-operatively. You can't blink for your prosthetic rehabilitation. So whenever all the dental implants should be placed prosthetically driven. So that comes into our diagnosis as well as treatment plan. And inventory, we should be very sound with our inventory. Inventory is nothing but your materials and gadgets which you are going to place your implants. So diagnosis and treatment plan, we start from our photographs, patients' profile photographs, occlusion photographs, as well as intraoral photographs, what are the, and X-rays start from if it is a single implant or two implants to multiple implants. You start from your RVG if it is a single implant, or your intraoral periapical radiographs to your OPG, then your CBCTs and CTs should be. Then model should be placed, and our occlusion, you have to articulate and prosthetically design your treatment plan. Then you move to our other procedures. Then diagnostic wax up should be used, and interocclusal clearance. How Arul told that there will be minimum of 7 millimeters. Sometimes we go for a screw retained procedures. We can have up to 5 to 6 millimeter can be also manageable, but definitely check for interocclusal pre-operatively. Then you take the patient for implant surgeries. Otherwise, you can place an implant very good and have a good stability. Your prosthetic part will be questioned here. Then check for mouth opening and the movements of the jaw. Everything should be come under consideration and make a surgical guide. Now there are CAD/CAM related surgical guides are available, as well as you always you do your implants most probably with your surgical guide. If it is one or two implants as a beginner in your part of region, you don't have a surgical guide, then your very good knowledge about your surgical technique and skill will come under action. And inventories always before starting your procedure, check for your implant inventory, like your physio dispenser is working properly, and how which RPM, if it is 1000 to 1200, according to the D1 D2 type of bone, you have to manage your RPMs, everything. Then spare ratchets, always have one, don't have only one ratchet, you have two or more ratchets if possible, because always inventory is always in your implantology, always it is having your spare ratchets very very good. Sometimes your ratchet won't work if it is fell down, it is not sterile. Immediately you can't go for any other help from your friends or nearby, or you may go autoclave again. So you always have a spare ratchet, spare hand pieces, and everything, cover screws, many cover screws you should have. Even though it will get it in your implant, sometimes autoclavable cover screws for emergency purpose. And check your biomaterials like your suturing as well as your bone grafts, everything also available. So this is the quick schematic diagram. Whenever you place your implant, it will be in a, most probably if it is a mandible or maxilla, you have to place it in a proper center position of your alveolus. Sometimes the angulation may be needed on the posterior regions because the mylohyoid fossa will be there. So mild lingual inclination for your mandible and little bit labial inclination on the posterior, and your anterior labial inclination for your maxilla. But whatever angulation you have to give, then you should have 1 mm on the buccal or lingual or palatal side if it is maxilla. And in between the implant and the tooth, why there is a 2 millimeter is nothing but then only you can give your prosthesis. To accommodate minimum, you have to give 1.8 to 2 millimeter in between the tooth as well as the implant. So crown height space already discussed. You should know, you should have a good clearance to have a good prosthesis after your implant placement. And coming to the treatment planning, whenever you are pre-operatively, always medical history is very very important. So straight away, whenever you convince a patient, don't go for without any blood investigation or any asking about any histories, don't go for any minor surgical procedures. So always medical and dental history, how the tooth loss happened, whether due to trauma or periodontal any dental history should be evaluated. And if there is any periodontal stability adjacent to, then you have to think about the complete curettage and oral prophylaxis and maintaining and giving enhancement to the other periodontal compromise to then go for your implantology. And diagnosis, definitely go for your radiographs. If available, definitely go for your cone beam CT. Then only it will give three-dimensional view of your crustal to inferior region as well as buccal to lingual, how much space you have, and this helps in your selection of implant, because wherever more bone is available, you can give more amount of structure of your implant to gather your osteointegration. So whenever you are talking about osteointegration, if you have more bone length, you use your more length here, 13 mm or 16 mm of implant in your anteriors. If it is very shorter, you use your width of the bone. So definitely your CBCT will be very helpful. And identify the anatomical variations, because we don't worry about anatomical landmarks, but we worried about anatomical variation like extra canals or extra foramens or any different anatomical region. So then importantly, you explain to the patient about the procedure, what you are going to give, because most of us, we have a consent form with us for our root canals, routine root canals and dental procedures. Same thing for implantology also, you make the patient educate about implantology, and then you have to teach the patient about how you also have the responsibility of after placement of implant to carry out the implant successful for the patient. Then you have to make a consent form. It will be like a written consent form as well as video consent form. Everything can be handled pre-operatively, because after any complication, no patient will accept for a consent form to sign in post-operative after getting a complication. So pre-operative, you get a verified consent form, and you have to check with your prosthodontist or you analyze with your prosthetic rehabilitation and get a consent from them, and treatment with the, you also include the prosthodontic consent. If it is a single tooth, if you manage, it's okay. You can still, you can get a prosthodontic consultation and get how the occlusion is going to behave, how the pattern of occlusion is going to behave, everything. Then intraoperatively, the two things only I will mention. How you are going to do most of the cases, 95% as a beginner in a local anesthesia only. If in your part of the country you are practicing under sedation, then the airway will be protected properly with your anesthetist support, and monitor vitals, even though in your local anesthesia as well as your sedation, both the procedures you should monitor the vitals meanwhile during the intraoperative, because most probably implants, we are 60 percentage geriatric patients is coming for our implant placement. So you should concern about your vitals, and surgical guide should be used, as well as check the drill speed for every surface, because whenever you do your osteotomy from the pilot drill, from the sequence osteotomy, your osteotomy changes, sequence changes, you have to, and the D1, D2, D3 type of bone changes, your RPM will be monitored. And intraoperative radiographs are very, very important after giving a pilot drill, after sequence drill. If you are doing single implant, it is going to more labial or lingual. To avoid that, from the pilot drill itself, you have to take a intraoral periapical radiograph and check the angulation comparatively. If you more than one implant, two implants means you have to check the parallelism of the implant. And final torque value of every implant should be noted in the intraoperative. Post-operatively, you should go for proper counseling to the patient, as well as post-operative mouthwashes and chlorhexidine mouthwash. You have to prescribe for the patient. If you done a bone graft, regular pediatric check, as well as post-operative after placement of implant, next day you should call the patient. If possible, you have to check. Then from the 1 week, 10, 2 weeks, you have to check and schedule the follow-up. Call the patient if patient is very little bit distant, any discomfort is there, any problem. If it is a minor suture dehiscence or minor soft tissue, immediately you can recall the patient and you can come over the complication. And take the radiograph post-operatively after 2 weeks or 3 weeks and confirm that how the bone, any radiolucence, because immediately you can't appreciate any radiolucence. Still, any canal impingement or any impingement intraoperatively also you check, and any displacement happen also. If there is no stability, you have to check. So implant placement protocol, already we have told that implant planning will be very, very in a good manner. Treatment planning and evaluation and anatomical structure should be properly screened, and measure the alveolar bone width, and then only you can predict how much width and how much length. Because Dr. Arul told that there will be a shorter implants from 8 millimeter, 6 millimeter up to 13 to 16 millimeter. Width also starting from 3.3 to 5.5, 6. Some companies differs. So whenever you select an implant, you should know about how much volume, how much width and the length you are going to place. And you also have other one number less as well as one number more implants in your hand, because whenever your osteotomy is oversized, you have to come over with your larger implant if the bone volume is good. If you are underestimated and drilled or wrongly little bit angulated, you have to, if you have adjacent site, you have multiple implants in your hand to come across this kind of complications. And bone grafts, if sinus lift is needed or not, you should know. and select most suitable implant size most probably. Otherwise also you have some options in your, like in your hand, other implant sizes also. Because with the one implant or predicted size, you can't do an implant always. So then only it will reduce the surgery time. So timings of implant placement will, whenever you do an immediate extraction and do an implant placement, that is called as immediate placement. After 4 weeks or 8 weeks, somewhere patient lost the tooth or extracted somewhere else and convinced after 4 weeks, whenever patient wants the implant, that is called as yearly placement of your dental implant. So more than 12 weeks to 16 weeks, it is called as delayed placement. Sometimes extraction was done elsewhere 6 months, 1 year later, or 2 years before. Then the patient comes for implant, that is called as late placement. So immediate placement, early placement, as well as delayed placement and late placement, or some timings of implant what we are going to place. So there are many articles and studies that immediate after extraction, immediate placement, there will be a good osteointegration takes place. Otherwise, if it is 4 months or 6 months later delayed or later placement, especially in occlusal regions like posterior regions, you have to do a 2-stage surgeries and leave the implant for osteointegration. So protocols, as a basics, we know there are two protocols as follows universally. One is 2-stage surgery, another is single-stage surgery. Two-stage surgery is nothing but you have to do a flap or flapless, and you can place an implant into a region, especially in the posterior region. Then leave it for a healing phase up to 4 months to 6 months for your posterior mandible as well as maxilla. If you have done a bone grafting, you should leave up to 1 year. Sinus lift in the maxilla, bone grafting in the mandible, you should leave 9 months to 1 year. But newer protocol says if the Newton value is 35 to 45, sometimes you can go for an immediate prosthetic rehabilitation also. But still, as a basic, as a beginner, we can follow 2-stage. Second stage, in this 2-stage, after the osteointegration, after 6 months, you can again do a surgery, minor punch out of the soft tissue or removal of the soft tissue, and see the cover screw and remove the cover screw, then put a healing cap. Then again, you have to wait for healing period to gingival former. Then you have to go for a prosthesis. So this is 2-stage surgery. As well as single-stage surgery, the same protocol, implant will be placed and go for a provisionalization and osteointegration takes place. Then you have to go for a final abutment. Here, the healing abutment was not able to place. So this is 1-stage surgery. So surgical pace, I will go quickly because there is a little bit time only. So surgical pace, you should know what are the armamentariums you should know. So stick to your proper local anesthetic protocol. Sterilization is very, very important. And asepsis before your surgery, mouth washes and painting up with your betadine or your asepsis of the operating zone. And you have to proper autoclavable instruments and gowns should be used for your dental minor surgical procedure. And if you are going for flapless, there is no need to worry about that. You can use only tissue punches for your pilot drills. If you are going for a flap surgery, you should use a 15 number BP blade and your stent should be used. If using your incision, it should be full thickness. Most probably some advanced cases you can need partial thickness grafts, flaps are used. But here, as a beginner, what I will emphasize for minimum of 20 to 50 cases, you put an incision, see the bone, buccal bone, lingual bone, crustal region, then you have to place your implants. Then only you have the confidence of placing it properly, not too lingually or too buccally. Then it will help the open approach, because beginners always think open approach is difficult because putting an incision and reflecting a flap. But I will suggest that once you are confident in your open surgery, then you can go for a flapless procedure, because some are disadvantages also there in your flapless procedure. So full thickness decoperiosteal flap is raised and you can see the buccal and lingual bone, then you can start your drilling. So this is your pilot drill. Olden days there will be a round burr. Nowadays pear shape or lancet type of thing for, this is your marking drill. Then comes to your pilot drill. After the marking drill for 4 to 5 millimeter, then comes to your pilot drill. Pilot drill has a width of 2 millimeter. Then comes your sequence drills. According to some companies have color coded, some companies are having a marking on the handle of this sequence osteotomies. Here you can see 6 mm, 8 mm like your periodontal probe. So then only some companies comes with a stopper, so you can know how much desired length you are supposed to go. For example, we are planning for a 5 millimeter width as well as 11.5 millimeter of length. You should go for 11.5 millimeter of length. So this is your head stiver to manipulate your cover screws as well as healing caps and for placing your abutment screws. Paralleling pin is nothing but, and depth gauges are available whether you have done an osteotomy up to the level of desired length like 11.5 millimeter. Then you have to put a depth gauge as well as if you are more than single as well as multiple implants, you have to place a paralleling pin and check the parallelism from the bilateral. If you have done any little bit angulation difference in your bilateral, it can be easily changed in your sequential. If you are using a stents, it won't need it. But whenever you starting your as a beginner, you start your basic implantology with your free hands. Definitely, you have to make use of this tools. So this is nothing but you are starting with your twist drill or bilateral, then sequence osteotomies can be done and your implant should be placed. So incision should be placed up to the bone. Then how much length you are going to give for example, 10 millimeter or 11.5 millimeter or 13 millimeter. The desired length should go for your bilateral as well as sequence osteotomies. But due to D1, D2 or D3, if it is a D1 bone, complete sequence osteotomy should be done for 11.5 millimeter, the desired length. But if it is a D3 or D4 type of bone, sequence drill can be shot up to 10 mm, 8 mm after the 11.5 mm because your implant will go and the active threads, there are reverse buttress, there are spare, there are many modifications in the thread levels. It will go and engage the buccal and lingual or cancellous bone. So according to D1 and D2, D3, the sequence will be little bit changes. Always make a small thread with a twine or a suture thread because the paralleling pin or small thing which here it will slip and patient get aspirate. To avoid that, you have a long tail how you use for endoremus. So this is very, very important. Drill to the desired up to the L and you should go for the up to the length which you have desired length you have measured as well as the sequence of study. If there is a 5 diameter of implant, and if it is a D1 bone, you have to go up to 4.65 or 4.85 according to the companies. It will change the sequence of study. Then you have to place your implants. And you can use your countersink also for the crystal region to accommodate because whenever some design of your implants start from the crystal region and taper towards the attack. So the osteotomy changes will be, the sequence drill changes will be there little bit if it is a D1 or a D3 type of bone. After the placement,
conclude your presentation. Thank you.
Yeah, thank you. So these are some clinical cases, just I will rush through. So labially always primary stability comes from the apical region. So you should have any granulation tissue, you have to curate it and you have to make a bone grafting. And especially as a beginner, whenever you deal with the knife edge, you should remove at least for 3 to 4 mm of the knife edge, which you are clearly seeing, and make the region, you can use your burr or a technique or a piso to make the bed very flatter to make our implant on the crustal region. Then only there will be no crustal bone loss will be there. Again, I will have to mention only one thing. Whenever you do your implant, just submerge 0.3 mm to 0.5 mm to counter attack that. After the healing, sometimes crustal bone loss will be. There are many studies 0.3 to 0.5 mm. So to avoid that, you have to counter little bit deeper into the 0.3 mm into the occlusal level. So this is nothing but your healing cap as well as you have to. So before surgery, you should know about your anatomy, radiology, and adequate implant training. And don't worry about failures. Always accept failures and learn from them and do your proper basic implantology. Then come to advanced implantology. Thank you for giving the opportunity. Thank you. Thank you. Thank you, Ruben.
Thank you, Dr. Alaguvel. Thank you, Dr. Arul. It was definitely an eye-opening session, giving us the basic principles and protocols. I know you need another 5 hours to speak on the introduction because it's always, implantology is this one field I think you can never completed. There's no timings, there's no end to a presentation. Good morning, participants. Once again, a warm greetings to you. I need you to tell us, since you all attended this session by our two very dynamic speakers from all the way from Tamil Nadu, tell us how you found the presentation. If you found it awesome, if you want to learn more, if you want a once more session, if you want it twice more, if you want to be a part of the courses that both the doctors have been successfully conducting in India, in various parts of India, please tell us. Tell us that you liked the session. Tell us that you would want to know more. You would love to hear both the speakers once again. Please tell us so that we know how we can cater you in the near future. Before I forget, I proudly want to tell you that Dr. Arul Prakash as well as Dr. Rajan have been successfully conducting courses in India, especially in South of India. To everyone who's in South of India, of course, due to the lockdown issues, it's a little difficult to have an actual hands-on course, but definitely I spoke to Dr. Arul as well as Dr. Rajan, and they are more than happy to conduct an online course as well as courses in near future. So all of y'all who are interested to be a part of various courses, right from basics of implantology to advanced courses, Dr. Arul, Dr. Rajan and their entire team have been doing a wonderful job in helping students like you to learn the basics and to learn the actual aspects, the nitty-gritties, as well as to understand the complications. Because I feel if you don't understand the complications, it's very difficult to move into your practice. But before you understand the complications, it's very important to understand each and every basic protocol. And once again, I request you to get in touch with our speakers, Dr. Arul Prakash and Dr. Rajan. In a very short while from now, I would be requesting both of them to share their contact numbers and their email IDs so that you can get in touch with them and you can make the best out of their courses. They're having these short courses in Tamil Nadu, and the courses that they have been conducting have always been these houseful courses. And for the number of people who've attended the courses, we've seen the fact that they've been beautiful courses, and they're not just those courses which give you a gist. They are these courses which help you to understand the exact protocols when it comes to basics of implantology as well as the advanced level of implant dentistry. Once again, for all you people who are interested to be a part of the courses, please do get in touch with Dr. Arul Prakash as well as Dr. Rajan. In a short while from now, I would be requesting them to share their contact numbers. Moving on to the next part, before we come to the very important part, that is the question answer session for this presentation, I would like to tell you that all you people who are interested for the participation certificate for the world's first virtual implant expo, we are having one certificate for the complete expo, and I'm very happy to tell you that the participation certificate has been internationally accredited with 30 CPD points, which are awarded by a German dental association. So everyone who's interested for a certificate can email us at edu@dentistchannel.online. I repeat, edu@dentistchannel.online. This participation certificate is for everyone, and the participation certificate is anyways available for prime members of DentistChannel.Online. For the ones who are not prime members of DentistChannel.Online, are requested to email us at edu@dentistchannel.online. Sorry. I now request Dr. Rajan and Dr. Prakash to kindly share their contact numbers as well as their email IDs so that our participants can get in touch with you for the near future if you are conducting any courses. So please do share your contact numbers.
Yes, sir. Yes, Ruben. So questions, there are many questions. I can type it or I can answer it.
Sir, what I would do is I'll tell it to you, and we can cover questions one by one.
Yeah, sir.
All right, friends, if you have any more questions, please feel free to post them in the Q&A box only. Please don't put your questions in the chat box. It becomes very difficult for us to take your questions and to make sure that they're getting answered. So we start with the first question from the question answer session. What does the laser mark mean? Can you please explain?
Yes, sir. Next question. So laser mark is nothing but whenever you have our implant systems, because we repeatedly autoplay, what will happen sometimes, any striations.
Doctor, can you be a little louder, please?
Yeah, now you are able to hear?
Yes, sir.
Yeah. So laser marking is nothing but whenever in your sequence drills as well as you have like your periodontal probe, there are striations, 8 millimeter, 10 millimeter. Same thing can be given by laser markings. So whenever you do more autoclaves, it won't be have diminished. So you can easily, after the case of 40 cases, 50 cases, you are able to see whether properly it is a 6 millimeter or 8 millimeter. It is associated to the markings. That's all. Thank you.
Thank you, doctor. We move to the next question.
Yeah.
So my question is, if a patient is 65 to 70 years of age, or if he or she are greater than 65 years of age, and if their alveolar bone density is not good, but they insist for having implants, then what should we do?
Yeah, thank you for the question. So whenever the bone quality is not, the density is not that much very good, it is like your D4 type or it is very brittle, you can, if still patient want to go for implant, so you can first of all explain the patient because this bone doesn't shoot that much of more implants to have the prosthesis, because we have to think about the post-operative prosthetic rehabilitation also. If patients have definite on your fixed processes, you can go for overdentures, like minimizing the implants. Only two implants you can place on the anterior mandible, and you can go for overdenture. You can give other options. Still, you are putting all on four on the maxilla and mandible. You can minimize the implants. Thank you.
Thank you, sir. Next question. Sir, in case of immediate placement in 11 and 22 region, can we go with immediate loading with temporary
Yes,
after
sir.
the emergence profile is evident?
Yes, sir. Because whenever if it is an immediate extraction, whenever you concern about that, only the thing is aesthetic, because the tissue healing will be happens after 3 to 5 months. So if you have achieved a good primary stability up to 45 Newton, 40 to 45 Newton, definitely you can go for a temporarization. Then after you can inform the patient. Then after 3 months to 6 months, good healing, soft tissue healing takes place. Then you can go for a permanent rehabilitation. Thank you.
Thank you, doctor. Move to the next question. What will we do if the adjacent tooth is tilted?
So whenever adjacent tooth is tilted, whenever your drilling protocol is going to encounter the root, definitely you have to change the angulation of the implant. If it is a single tooth, it is a little bit difficult. If it is a 2 or 3 spaces available, you can little bit make the angulation little bit proper. But if it is a single tooth, you have to make your angulation of your implant. That's why the pre-evaluation is very, very important, because always make a strength how the prosthetic crown is going to come. Then the available angulated abutments can be up to 15 degree. You can give, means you can give. Otherwise, it is more than custom made angulated abutments are also available. But if it is an anterior region or aesthetic or a high occlusal region, it is questionable. So you are supposed to go for other kind of treatments or other treatments. Otherwise, if it is into the limits, there will be angulated abutment can be placed. You can make your implant angulated, and you can place an angulated abutment, get it to a normal occlusion.
Thank you, sir. I now request Dr. Arul Prakash to
Yeah.
take a lead of the question answer session. Next question. In osteoporosis patient, what is the treatment protocol, sir?
In osteoporosis patient, in the initial phases, not to take as a procedure, do it some other prosthetic measures and replace the tooth. That's in initial phases we can do like that only.
Thank you, sir. Next question. Doctor, do you suggest vitamin D and calcium levels mandatory checkup before planning and advise supplements?
Not necessary. We can identify the depends on the age of the person and the clinical and radiographical history, and radiographic measurements. We can identify the bone quality. If the patient have the history of vitamin D or some other deficiency or bone quality, bone deficiency, we can go for another investigations.
Thank you, sir. Next question. Mandibular screw loosening is always more. What is the reason?
Mostly screw loosening will be in more in single implants or single prosthetic. If connected by another that implant, the screw loosening will be less. And in the mandible, they have anti-rotatory forces will be high, especially in the molar. And different companies have different type of screws. But my opinion, both maxilla and mandible have the same pattern of screw loosening.
Thank you, doctor. Moving to the next question. Are markings same for different companies on the drill? I heard that some companies have different drills for different type of bone. Is it true? Please enlighten us with some knowledge on it.
The marking is differ from that type of bone. It's not between the relation between the bone and that marking of the drill. The marking mainly for measure the length. For example, if you want to place the 10 mm implant, if we have a 10 mm length, we have to drill the bone up to 10 mm. So that only we have the marking. Okay, some companies are, for example, in most of the internal hex companies, Norris, and some like companies, we have 6 mm, 8, 6, 8, 10, 11.5, 13, 16. Some other companies 6.58, depends upon their implant size. They have a various, for example, we have a 6 mm implant, so we have a marking at 6 mm. Some implant companies have a minimum at 8 mm implant, so they will start at 8 mm. There is no different for different type of bone. There is no different drill in normal conventional types.
Thank you, sir. Next question, very common question that we've received. Please tell us about your courses and which course are you conducting in the near future?
We are not yet decided because of the lockdown. Once the lockdown is over, we need to contact with patient hands-on. It's in Tirunelveli. We are ready to conduct courses in other cities also if the people are willing.
Thank you, sir. Any more questions, participants?
The best pre-operative and post-operative medications, Dr. Praveen. That's a normal extraction procedure. It's like an implant is not nothing, but it's like a normal extraction, like normal extraction procedure. So we'll give a pre-operative of antibiotic, and post-operative we will give 5 days antibiotic with painkiller.
Thank you, sir. Next question. Is it necessary to take Cbct for all cases?
If you take, it's advisable. If you have accessibility to Cbct center, it is advisable because we can clearly plan the plan and we can place the implants.
Thank you, sir. I'm taking some questions from the other social medias that we've got the questions from. For example, Facebook. What is the failure rate? What is the failure rate of basal implants?
Basal implants, basal implant failure rates. Every treatment depends. The failurity depends upon the operatory procedures and case selection, and in post-operative prosthetic restoration. So as our experience, we have more than 90% of implants are, whether it's a basal or conventional, it's successful.
Thank you, sir. I think this should be the last question. For single tooth rehab, what do you suggest? Cement retained or screw retained processes?
We already told the cement retain or screw retain. It depends upon the available vertical height. If you have 8 mm, more than 8 mm occlusal clearance, we can go for a cement retain. If you have within 6 to 8 mm, 7 to 8 mm length occlusal clearance, we can go for a cement retain. Screw retain. So screw retain and cement retain cannot decided by the patient. It should be decided by during that measurements of presence of interocclusal clearance.
And more than that, screw retained, always you go for screw retained, then only you have the opportunity of retrievability of your crown if future any screw loosening or any problem. If you go for a cement retaining, especially, sometimes it has its own disadvantage also. So single tooth also, if it is good, you can go for a screw.
Thank you, doctor. Inferior alveolar nerve, do's and don'ts while doing molar implant.
So inferior alveolar nerve, you always from the crustal region to inferior alveolar nerve, there will be a desired length from your Cbct or radiograph. You have 11 millimeter or 12 millimeter, means you can just 1 mm to 2 mm, you can just cut short your implant size and you can go always, it is safe. Sometimes, most of the cases, it won't allow because the patient come with only 8 millimeter from the crustal region to the inferior alveolar canal. So you can't leave 2 millimeter. At that time, with the caution, with your after the pilot drill, sequence osteotomy can be little bit 0.5 mm or 1 mm enlarged, not to the apex, just short out, because pilot drill is 11.58 mm means you should sequence drill will be 7.5 mm. You can just make the osteotomy wider, then you can place your implant, because the inferior alveolar canal, only one good thing is The canal cortical bone will be little bit thick. So your pilot drill or sequence drill immediately it won't poke into the canal and it won't go. So it will be little bit have our freedom to come up to the canal level, then you can place it. If because the paresthesia or anything will be post-operatively, if there is any paresthesia present, you have to remove it. So the cortical bone of your inferior alveolar will be little bit comparatively the cortex is thicker. So don't worry about that.
Thank you, doctor.